Hello, thank you for joining me again if you've already watched a couple of these little videos. Today I'll be going into implementation science. So it's a term that some people might be familiar with, but I think it's perhaps less well recognized than it possibly should be or could be. But it makes sense. And I think it's very, people will understand the concept behind it very, very easily because it makes sense on how we practice as health professionals, I think. So implementation science, it's the broad category of science that aims to bridge the gap between research and evidence. So it's the systematic study of methods to promote the systematic uptake of research findings and other evidence-based practices to improve the quality of healthcare. Implementation science itself encompasses implementation research, which is the process of investigating how to implement interventions, and implementation practice, which is the process of actually implementing something in a structured and evidence-based manner. When we conduct research, develop a guideline, design an intervention, that's only the first step in changing practice. As I mentioned in the behaviour change presentation, if you've seen that already, changing practice is complex. We live and work in complex systems, and simply writing a guideline or creating an intervention is not enough to change practice or change behaviour. To change practice and translate evidence or interventions into real-world practice, we need to acknowledge this complexity and particularly the variability in the environment, the context, individuals, and the delivery mechanisms within systems. So there's a commonly cited statistic, I think from the early 2000s, that it takes 17 years for evidence to reach practice. And implementation science essentially aims to reduce that gap by actually effectuating or applying evidence or an intervention successfully, and also more generally to create transferable and generalizable knowledge. So learnings from discrete projects and specific research, the intention is to be able to benefit the wider research space and the wider healthcare space. So although much of this is about to be, is going to be about applying existing interventions and how we actually operationalize those in practice, it is broad enough implementation science so that we can use the methodologies in flexible ways. So we can use the implementation science frameworks, and I'll go into a couple in a moment, in order to design, to implement, or to evaluate something. So some frameworks, models or theories can be used to design an intervention from the beginning. We can use it to implement something that already exists and implement it in an evidence-based way. Or we can use it to evaluate after the implementation to see if it demonstrated fidelity to the implementation process and if it was effective and how it might be improved in the future from an implementation science lens. So as I said, there's a range of frameworks and models available. So there was a systematic review and 143 theories, models, or frameworks were found. There's no perfect framework. There's no one of them is the best. There are those that are much more common and frequently cited and referenced and used. There's many similarities between them, but they've all got different purposes and uses and evidence. I've put in here the IPARIS framework. That's one example. It's a determinant framework. So it stands for the Integrated Promoting Action on Research Implementation in Health Sciences. You can see why they call it the IPARIS. It was originally developed in the 90s in South Australia, in Adelaide, and it was updated in 2015 based on feedback and a range of publications that had sort of identified some potential gaps in that framework. It's a determinant framework, which means that it's used to identify the barriers and the enablers of an intervention and its implementation. It is, however, often used to analyse an intervention, so not necessarily to prospectively plan one, but it's often used in the literature to evaluate an intervention and why it may have may have worked well or may potentially work better in future. But it was originally designed as a planning tool to integrate new services, and specifically it was designed to be used in healthcare settings. So it essentially holds, and there's an equation there that's nice and easy to follow, that for the successful implementation of an intervention, we need to consider the things in brackets. So the innovation, so what is being implemented, the recipients, so who's being affected, and the context. So where are we doing this? And that involves the immediate context. They delineate it as the micro, macro, and the meso levels. So the immediate context, as well as the middle layers and then the outer layers. So organizational, governance, political contexts, all that sort of stuff. So, and these three constructs are guided by the F, the facilitator construct. And that is an all-encompassing role that involves the overall guidance for the project. So when you're implementing something or you're evaluating the implementation of something, there needs to be someone or a group or a team that is facilitating the implementation, and that's what ties it all together. Another similar framework that I wanted to discuss is the CFIR, or the Consolidated Framework for Implementation Research. It's by far one of the most common that you'll encounter in health research, and it's very, very similar to the IPARIS framework. So it's got 5 constructs, and you'll see that they're quite similar. It is also a determinant framework, and it was produced by combining a range of other theories and models and frameworks to develop 5 overall domains, which are those 5 there, as well as 48 smaller constructs and then 19 sub-constructs. I'm not going to go into detail on those, but you can find them yourself. The 5 domains below, as you can see, are, like I said, very similar to IPARIS. We've got the innovation, which is what's being implemented, whether it's a novel treatment, an education program, or a new hospital service. The outer setting, so it's the setting in which the inner setting exists. So for the inner setting is a hospital, then the outer setting might be the hospital network or the state, or it's an aged care organisation. Now, the inner setting is the direct setting in which the innovation is being implemented. So it might be a single residential aged care home, a hospital, or non-healthcare related, a classroom. The individuals, so the people involved, those delivering the innovation, receiving the innovation, the leaders and the other team members, and the implementation process, so the activities and the strategies that are involved in implementing the intervention. So this is an example of how the CFIR framework can be used to evaluate an innovation or an intervention. So the authors of this paper, the application of the CFIR to improve Clostridium difficile infection management in district hospitals, they aimed to develop an intervention in South African public hospitals and analyse the intervention and the implementation process to more effectively manage their Clostridium difficile infections within the hospital that are already there. So their internal processes. So they did this with a checklist intervention across 3 hospitals. So they used retrospective medical records of people hospitalised with C. diff, as well as interviews and focus groups to identify the barriers and the enablers of the intervention. So they looked at 3 different hospitals and who was implementing it well, who was implementing it not as effectively. And what they found was that there was really high uptake in one of the hospitals and lower uptake in the others. So they could identify, based on the CFIR constructs, those 5 that we mentioned before, what was different across those hospitals and what might be driving the successful implementation of that new intervention. They identified the barriers and enablers linked to this uptake. So what they identified was there was tension for change amongst some of them. They had peer intervention champions in some of the hospitals, or one of the hospitals rather, or successful peer intervention champions, leadership champions, and the simplicity of the intervention also drove success. So they identified a number of CFI constructs that correlated with the effective uptake in the certain hospitals. So they listed those three main constructs that they could map their findings to. And here is just an excerpt of that. So this is related to the intervention itself. They found that they could adapt existing interventions for the local healthcare setting and their resources. And they also found that the simplicity of the intervention suited the workings of that particular hospital. So that's the use of the framework to evaluate and improve an intervention. And in this next study, which was conducted in Australia, we'll see how it's used in the design phase. So this was a study conducted on the Monash University psychotropic guidelines. And I believe my image might not be working there, but that was a screenshot from the Monash University. It's the clinical practice guidelines for the appropriate use of psychotropic medications in people living with dementia and in residential aged care. They also need an acronym. So the authors aimed to prospectively, which means before it's undertaken, identify the factors associated with implementing these guidelines into practice in order to develop strategies to implement it successfully early on. So before implementation, they wanted to identify what was going to most successfully be associated with the positive outcomes of this guideline. So what they did was they conducted semi-structured interviews. They recorded them, transcribed them, and then undertook thematic analysis. They then undertook deductive coding to the consolidated framework, the CFIR. They used 3 of the 5 domains to do this. If you're unfamiliar with deductive coding, please go to my qualitative research presentation. I go through it very briefly there, but basically it's coming in with a theory. It's not generating the theory from the data. So they came in with the CFIR as a lens to interpret the data that they recorded and transcribed. So what they found, they undertook 33 interviews with different participants, so mostly healthcare professionals, but also consumers. And they identified the aspects of the 3 constructs that would impact the implementation of these guidelines into clinical practice. So the outer setting consisted of regulatory changes, an increased workload from implementing the guidelines, and workforce demands. The inner setting had health digitization, governance, and culture that they believed would affect the implementation of the guidelines. And from an individual perspective, the mindset towards psychotropics and the capabilities of the workforce were also believed to potentially, and again, this is done before the guideline was actually implemented, potentially impact the implementation of this guideline. From this, they went further and described 4 primary implementation strategies for organizations. So they provided practical guidance for organizations when implementing these based on their findings in the results. So they identified that recognizing the workforce pressures within organizations was important when implementing these guidance. Leveraging recent efforts in aged care organisations. So, following the Royal Commission into Aged Care Quality and Safety, many organisations had already made efforts to reduce or optimise the appropriateness of psychotropics. So, leveraging these efforts was seen to be an effective strategy. Support for organisations on the local use of data was also a suggested strategy so that they could maximise their use of available data, and also supporting team functioning, which was briefly touched on that was a potential barrier to implementing this is the workforce. So effective interprofessional collaboration was seen as key to this. So major takeaways from this very brief introduction to implementation science. It's a useful realm to design, implement, and or evaluate health-related interventions. There's many theories and models and frameworks. They're often quite similar, but they all do have different functions, and they primarily focus on the context in which you're working, the individuals that you're working with, and the innovation that you're working with. So as I said, implementation science conceptually might be a new term, but it makes sense. I think we organically know that these are the important factors to consider when we're trying to do something or plan something. And I hope it's also useful to see that it can be useful in research, not just in planning research and not just in evaluating the outcomes of research, but also it's a useful lens to communicate the findings of research in a way that makes sense to people and is practically able to be applied in clinical practice. Clinicians don't necessarily have the time to read through these data-heavy and concept-heavy papers. They want and would benefit from clearly applicable guidance and strategies. So it's useful to be aware of when you're undertaking any sort of research, but particularly in these sort of complex settings where there's multiple moving parts that we need to consider. Thank you again for all your time, and I will see you on another recording. Thank you.